for today. So today we'll be talking about managing COVID-19 disease, and we'll be hearing the experience from Australia. So this will be a learning session for a lot of us, and we'll also having one of us who will also give us a snapshot of what is happening in Kenya. I can see a few comments about CPD points. Kindly email us at knhcpd@gmail.com and we'll be able to address all your issues for CPD. Before you email us, kindly check on your portal to see whether the CPD points have been uploaded, because the team has also been working a lot on the CPD points. With that said, I'd like to invite Bahati Moseti to introduce himself and continue the session.
All right. Good evening, everybody, and thank you for joining. Nancy, I'm just going to start sharing my screen, and just let me know if everything's going on well.
We can hear you well.
Yeah, can you see my screen though?
Not yet. We can't see your screen.
All right. I think there's a problem. Okay, Zoom. Okay. Can you see my screen now?
We still can't see your screen.
Okay. Is that good now? I think
yes.
That should be run.
Yes, we can see your screen.
All right. Good evening, everybody. My name is Bahati Moseti. I'm an emergency and critical care physician in Perth in Western Australia. I'm an alumni of the University of Nairobi, and I've been in Perth now for 15 years. I came here in 2004 and specialized in emergency medicine and some critical care. So I've been requested to just give a snapshot. I hope it will be a real snapshot of how we have approached this pandemic of COVID in Australia. And I think everyone here has access to the internet and the numbers. And initially, you saw how how the numbers affected us. And luckily, we were very lucky that we did not get hit quite hard, especially Western Australia. I mean, part in Western Australia. We've seen consistent zero numbers, I think, now for a month, and we had very few numbers. But we did get a few sick people, and mainly from a cruise ship that landed in Sydney, and some people managed to sneak through to Perth, and those were the main, that was where the nidus of the infection was. The government has really tried. We have a federal government and state government. I think it's akin to back home in Kenya, where we have the central government and we have counties. And basically, the response has been coordinated. Initially, a few scattered, disorganized response, which luckily people got onto it very quick, and we managed to control the spread and flatten the curve, as it's known. So that's just an overview. That is, so as you can see, we are in the, that's, I don't know where Australia is here. So Southeast Asia, I think we are around Southeast Asia, and our numbers have been very low. But compared to the other Asian countries, I think we've really managed well. Just a comparison with the countries around us. You can see Australia, where we are. We managed, I think the red is expected projected numbers, and the black is how we have progressed so far. Interestingly, Singapore managed to initially control the infection, and they got a second wave. And just like us here in Australia, we've had a second wave in Melbourne, Victoria, from various reasons, which I'm going to just mention later on. So these are the cases in Australia. We've had a total of 19,000 cases. That I think I got this. This is the first case was reported on 22nd of January. So far, we've had 19,000 cases, total cases, and the recovered cases, as you can see, we've had 247 deaths. And about in the last 7 days within Australia, there have been 25 overseas acquired infections. There's been the locally acquired infections, the 3,867. That is Melbourne, Victoria spread, which was very interesting. Initially, returned travelers were quarantined. And interestingly, some of them managed to sneak away from quarantine, but the guards who are manning the hotels basically were the cause of the spread, and they started having relations with the people quarantined, especially sexual relations, and that just led to an outburst and an outbreak in the disease in Victoria. So we are very lucky in Australia. We managed to flatten the curve. We managed to keep our infections below our healthcare system facility. And I have to say, really, we have not been overwhelmed at all, despite the new outbreak in Melbourne, the second wave in Melbourne. We have not been overwhelmed, and our health system has coped very well. That's because of good planning, a robust health system that was in place before this pandemic. And maybe we've been lucky. So that's a snapshot. I'm in Western Australia, in Perth. And since then, we've had, let me just get this out of the way. So far, so far we've had, in Perth, we've had 670 cases. No new cases in the last 24 hours. Actually, in the last 2 weeks, we've had, actually last 1 month, we've had 0 cases. And in Perth, we've had 9 deaths so far. And all these deaths have been the elderly, infirm, some few nursing home patients, and of course, people with comorbidities, which is a common story all around the world. Victoria, of course, is the new hotspot in Australia, but we are anticipating this to come to us. There's been very tough measures in Australia, which I'm going to allude to next, and actually it's caused a lot of political discontent, and there are some cases in the Supreme Court right now about borders opening because the states took matters into their hands, and Australia is the most isolated. Perth is the most isolated capital in the world, and now we are even more isolated with this COVID. Okay, let's go next one. So we had the various tiers of response. We had a federal government response, state government response, and individual hospitals response. I am a director of my emergency department in Peel Health Campus, which is a local, not a inner city emergency department hospital with a HDU basically, which we converted into an ICU. And we have most specialties, but we don't have super specialties. So so I'll talk about our response later. So we had a very robust public health response. Our Department of Health here in Perth really was onto the ball very early with formation of something called SHIC, that is a State Health Incident Committee Coordination. ICU department, the ICUs basically, all ICUs in the state, public or private, were run by SHIC, and basically all emergency departments were expected to develop a workflow, which was supervised by SHIC and approved. And of course, during our training, of course, initially we didn't know what was going to hit us. We had looked at all this mortality from Europe, and people were really scared. And so we got onto it very quickly. We did SIMS. Each hospital was supposed to do SIMS training for its emergency department, critical care staff, including ICU and the whole hospital. And so we did a lot of SIMS, and where we practiced ED intubations, walked through SIMS to other areas of the hospital because we never knew which patients were going to have this thing, whether inpatients or outpatients coming in or emergency department patients. And there was always, people would stop SIMS. We did a lot of SIMS, and we'll ask questions, identify risks along the way, and do the SIMS all over again. And of course, we knew that the next, there was a potential that the next SIM would be a real COVID patient, and we did get some patients in my department. Actually, the first case in Western Australia came through my department. I saw this patient. So we learned some lessons from the SIM even before we started seeing these patients, and we knew that we were going to limit the number of staff at any step. We were going to liaise with St. John's Ambulance, that is our pre-hospital care, and if St. John's Ambulance were to get a patient with respiratory symptoms or suspected COVID, they were going to call the emergency department early so that we can meet them and escort them to an isolated bay in a safe way. We had COVID teams, and in the spirit of protecting staff members, the COVID teams initially were voluntary, and we had some exclusions. If you're over 55, if you had a comorbidity, then you worked in the green zone. We had to divide our EDs, which I'm coming to, into green and red zones. We had to divide our ICUs into green ICUs, a green zone and a red zone. And there are dedicated COVID spaces in the ICUs. And we were lucky, we stopped all elective cases. And so we had more beds. Western Australia, I think we have about, before this, we had about 700 beds. The population of Western Australia is 2.5 million. We had about, I think the whole state initially just dedicated ICU beds in the public. We had about 100 beds in the tertiary hospitals and about 40 beds in the peripheral hospitals. And there was a plan, the escalation plan was to go within 24 hours to go into 1,700 beds. And I think that was capitated up according to the population. So all hospitals were on the same page. Like in my hospital, my HDU has about 20 beds, and those beds very quickly, once we saw the first COVID patients, we upgraded them to ICU beds, 10 ICU beds, and we waited. So we managed about 3 patients in my hospital. So we were not scared that we are not going to get beds. Ventilators, we had enough ventilators, and there was an order. Of course, I think the whole world wanted ventilators, and but we had a lot of ventilators. Each hospital has each ED for each. I'd say for each 5 beds, we have a ventilator, the mobile ventilator. So we were not worried about ventilators, but of course, if it was going to hit us the way Europe was hit, there was always that question whether we had enough. St. John's were instructed not to bring any patient to the emergency department until the emergency department has identified a space for them, and the nurses were to go out and meet the patient in PPE with a senior nurse with research skills. And there's always a patient care attendant in PPE to follow the patient and clean anything they touched. And of course, we are going to use the shortest, safest route to a single room. And then there's only a nurse and patient who will go into the room, and the doctor will go in and assess the patient in PPE, do all your orders, and come out. So limit entry and egress into the room. There was also, I have to say here, initially there was a lot of panic. There was panic whether we had enough PPE, N95 masks and all that. And actually in my hospital, these things started disappearing. People started taking them home. So we had to really manage them and release only what was needed for the day. We also had it in that 3 people maximum in a room for intubation. And this was not, this was never going to be a teaching intubation for registrar. So it was the most experienced intubator. We had pre-med intubation packs, pre-med drugs. Every intubation cubicle had a difficult airway, a trolley at the ready outside. It was all going to be video laryngoscopy intubations. No notes in patients' rooms, and if stable, we are going to do we are not going to intervene for 30 minutes until we secure the airway. Other interventions. Of course, we are always going to limit staff involved in transfer and handling of these patients. Always avoiding suction if we are able, and we developed, I think not really developed, but we adopted a safe intubation drill procedure. So we involved anesthetists in our teams. So very sick patients will come in, and the COVID intubation team was either led by an ED FSM, that's a fellow, an emergency specialist, or an anesthetist. So we, of course, the anesthetists who were supposed to run the theaters, and there were emergency cases always, but we managed to get some of them, especially the young ones, nobody above 55, and they came and led teams. So in my department, we had 2 teams rotating 6-hour shifts, intubation teams, always 5 minutes to the intubation area. We had a special intubation area with either led by an anesthetist or led by a FSM, that's a ED consultant. Of course, we had protocols what to do about arrest per intubation. We had decided this beforehand, and we adopted the Safe Airway Society COVID intubation by ANZICS, that's the Australian New Zealand College of Anesthetists. Of course, we involved the executive in the hospital. It's very political here, with each hospital having executive who think they know what to do, but their job is always to make decisions, and our job is to make those decisions. They make good decisions. But overall, lessons from this scene really helped us. The state government also, we had, that was the federal response, the federal government response, which was, there was a travel advisories, all foreigners recalled, and all foreigners advised. It was really, I think, very intimidating, and people were asked to go back to their homes because the airspace was going to be closed. There was increased, normally resourcing of medical equipment is centrally done, but this time we were allowed to source our own equipment. We decentralized the procurement, and of course there was initial testing guidelines and initial limit of testing kits, which was an issue, and this was decentralized but coordinated in Western Australia with the SHICC. Our state government also, this now state government level response, we identified. So the question was, were we going, if we had a community outbreak, were we going to let patients just rock up into any emergency department? And what was that going to do in terms of our resources, staff, PPE, ICUs? We really had to plan this. We had not identified hotspots because initially we were not doing mass testing, and there were very rigid protocols about testing. And initially it was all returned travelers, and then we expanded it a bit, all respiratory symptoms, and there were these arbitrary figures of a fever of 38 degrees or 37.5. And these things kept on changing. Every day we got sit reps of indications for testing. So what we did here is we identified hospitals around the state. So we set up one tertiary hospital and set up a whole department, and we call the COVID hospital. So Perth is, there's north, south, east, and west divided by a river, and we identified one major hospital in each area where anybody who turned up to an emergency department or to a GP practice with respiratory symptoms was directed to go there if they could go. They were triaged in the car, did not come out, and they were told to drive on to that hospital, so to limit, so that all resources were concentrated there. The SHIC, that is the State Health Incident Coordination Committee, was made up of all directors of emergency departments, and we met every week. And basically our job was to coordinate resources, doctors, make sure we have enough doctors on shifts on all our hospitals, coordinate all HDU beds and ICU beds, and know where they are. And each day we could maybe now redirect ambulances to areas where there was not a lot of presentations, and we canceled all the surgery, as I said before. And then one thing which helped us, we set up drive-through COVID clinics, because we realized that patients came and they were told to drive on to the next hospital. They will not go there. So we had in every hospital, we had a drive-through clinic. So you come, you get swabbed in your car and you go home, and everybody was advised to download a COVID safe app, which everybody did. And then when you are swabbed, you get your notification of your test results from your mobile phone. And then with instructions to do if you're positive and what to do, and isolation and when to come to hospital. From the beginning, it was all home-based care, and we encouraged people to go home unless they're very sick. And we had protocols. Each patient came in, got a handout, or you just got it dropped on your phone, on a file on your phone when you drove through the clinic. We also had to coordinate our pre-hospital care. And this is really very big because St. John's, for example, if a patient collapses, St. John's ambulance will start CPR, and they will never call it. They'll never pronounce the patient dead until they come into the emergency department. And then a few rounds of resuscitation done. If the patient gets ROSC, then that's good. If they die, then the doctor has to make a call, or the emergency department has to make a call. So we had to educate them and say, look, if you get a systole for some time, for 10 minutes, you have to call it. We had to really develop a protocol and say, if you're picking up a patient from a nursing home and they have comorbidities, they are demented, they are 95 years old, 96 years old, we don't want them in the hospital. You can do the call outside before you come in. St. John's here also do out-of-hospital intubations, and we ask them to minimize all intubations. And of course, we had to change protocols like our STEMI protocols, because we have hospitals, specialized hospitals. So we did tell them, you can call us. There's always an emergency consultant on duty if you pick up someone with a STEMI. So normally they pick someone with a STEMI and they do the ECG and they forward the ECG, and we can start treatment in the ambulance and guiding them through the ambulance. And we said, so if you have a STEMI or a cold stroke, then you just go to the neurology hospital, you go to the cath lab straight. So we had to change all these protocols. So all early decisions in liaison with the AD, FSM, and the specialist teams, which took a lot of meetings, and finally, I think we convinced them to do that. And that really minimized AD crowding, emergency department crowding. Our inter-hospital transfer, we developed a special COVID cruise. Western Australia is very, very large, with some areas like some cities being maybe 2,000 kilometers from Perth. And we have flying doctors who pick up these patients. For example, we don't have cath labs in every center. We don't have a neuro centers. We don't have capacity to thrombolize strokes in many areas. So we have a very robust Royal Flying Doctors who are managed with telehealth. Emergency consultants manage these flights and dispatch the flights. So we changed the protocols, and we said, if you are a return traveler and you have COVID and you get this, we are not going to fly you. So we are going to manage you locally. Of course, this was fraught with a lot of danger, and it did happen. Many people, there were a few cases which have gone to the coroners, the coronial inquests, of which calls were made and limited care given because of suspected COVID. So it's opened up. Luckily, Australia is not very litigious. It's opened up some cases which are being reviewed by the coroner as we speak. In the metro area, we had specialized respiratory centers. All hospitals, tertiary hospitals with a respiratory center was put on alert, and beds expanded, and more staff located there. And as I said before, HDU and ICU facilities were centrally coordinated. And most importantly, there are a few private hospitals here. Although Medicare is free, but there's some ICUs for private ICUs, and these were taken over by the state. And that those who are under beds in that were under state SHIC, SHICC management. So it could be before a patient goes into the ICU, before a patient is allocated an ICU bed, there's always an ICU or an ED consultant who's on call for SHIC, and each case has to be run by them. So we had that in place. Yeah, so that's my hospital, Peel Health Campus. It's an urban district hospital. We have 35 emergency beds and about 15 short-stay beds, so about 50 beds in total in the emergency department. The whole hospital is about 300 beds, and we converted our department to ICU for COVID, for the COVID response. In my hospital, we address the following issues. So we address patient flow, as I've said before. From the department, we put a triage bay outside. Patients with respiratory symptoms were absolutely not to come into the department until they were assessed, and we divided the hospital into a green zone and a red zone, and all path departments were divided as such. We had to manage staff in my hospital, and we set up a telehealth, emergency telehealth system where all doctors, whether ICU or emergency, we have ICU telehealth as well. Because our hospital also caters for small peripheral hospitals. So from the small peripheral hospital, they feed into my hospital, and from my hospital, we feed into one of the biggest hospitals in Perth called Fiona Stanley. So we had telehealth. We set up a robust telehealth system, which was pre-existing, but we just revamped it, where any doctor who felt not comfortable and you had to show cause, but let's say if people above 55, I had 2 consultants who were above 55, so they went and did telehealth. Anybody who had a comorbidity, any doctor who had a comorbidity, a nurse who had a comorbidity, they went and did telehealth, or worked only primarily in the green zone. And of course, we had a unit to liaise with tertiary hospitals. Our plan initially was for all COVID patients to come to the hospital, and if they needed an admission, we were not going to use our beds. We are going to use the tertiary hospital beds until they are full, and then they will flow to us. Then we'll start admitting. And we are always open to the idea that our area might be least hit, so we were going to accept referrals from other regional hospitals. Yeah, so that's, I think I've talked about that. Talked about a red zone in my department, which it was a respiratory zone. Any COVID suspected patient went there, and you could not go into this zone without PPE, a mask, and of course, as I said before, initially we were worried, we're going to run out of PPE, so we made it such that you could go in. Doctors and nurses would go in for 2 hours. Then you can come out and shed your PPE, go for a break, and then you can put in a fresh pair of PPE and rotate the staff around. We had a green zone, which no contamination, but of course, these things are not hard and fast, so some mistakes could be made. I talked about patient intubation and the specialized airway teams, on-call rotation, and always 5 minutes from the designated hot intubation unit. And this was our endoscopy unit, which we changed into our intubation unit and took over the endoscopy unit when we stopped all endoscopies. And as I said before, this was no room for training registrars, so could not come and do airways there. And as I said before, we excused some staff members from being part of the team. I think I've talked about that slide. And of course, we are very, very strict about any aerosolizing procedures, and we needed that a single room if you're going to do any procedure that is an NIV, non-invasive ventilation, or high flow nasoprongs. We basically followed a consensus statement for safe airway principles of airway management and tracheal intubation. specific to the COVID-19 patient. This was developed by our College of Anesthetists here in Australia and New Zealand. This is now the document in force all over Australia and New Zealand. Of course, that's the policy there. So prepare, we checklist, ID single room environment, get your team together, get appropriate PPE, and there were always intubation packs. And always use buddy. We used to do buddy check for correct PPE fitting. You could not don PPE yourself. You have to have a buddy to check it for you. Check it for you. All our BVMs had viral filters. I think they're N100 or something like that. So video laryngoscopies always, and with the circuit, the ETCO2 circuit we noticed was leaking, was a potential for a leak, so we modified that. One area we struggled a bit was COVID investigations, and as I said before, initially there were very few kits, and the results. I'll give you an example. Someone comes to the emergency department with a respiratory illness, maybe just a community-acquired pneumonia, and they're put in the red zone. And after investigations and stabilization, this patient has to go to the ward. But the ward will not accept this patient until they are sure of the COVID status. So the COVID status, if this patient is positive, we want him to go to a tertiary hospital. The tertiary hospital is about 20 minutes. So are we going to move him? Are we going to put him in the ward? Our initial tests were taking 24-hour turnaround. The kits were really were very short. We didn't have enough kits. But luckily later as we went on, we have enough kits now, and we even have the rapid tests, which are 45 minutes maximum turnaround time of COVID testing, 45 minutes. So decisions are very quick. And we've expanded we initially expanded the testing, and now that like Western Australia, now we do not have a lot of cases. Now we are contracting the testing, and actually the testing now has gone back to the initial times where you have to have respiratory symptoms, fever, and contact or travel history. X-rays, we had mobile. This is the first patient I saw in my department with COVID who died later. That was a plain X-ray. So X-rays, we had mobile units specific for COVID area when we kept them there, and CT scans were a bit difficult to obtain, because that means the patient goes to the CT scanner, then it has to have a deep clean, and that will be 30 minutes before. So it was a bit difficult. That's the CT of the patient, of my patient. We then thought, this is in one of the tertiary hospitals. I work there one day a week. And there we thought, look, it's going to be difficult to we have about 60 emergency bays or 70 emergency bays. So we are not going to dedicate we're not going to dedicate mobile X-ray units, wait for the radiographer who will come and don PP and all that. So there we just started using ultrasounds. Most of us have that, and just go in and do your ultrasound and just try and identify some pathology and some of the pathology of a patient who was seen there. Yeah, so, and that's how we've gone. That's a graph showing the current COVID-19 cases in hospitals and ICUs right now in Australia. I think we are managing well, as I said earlier. So just a small ICU brief on what you are doing. So we know that, I mean, from what we've observed here, I showed you the numbers in Western Australia of what we've done. We found that 80% of the patients who are positive, and we have a very, very small sample, but I think this is also, this can be generalized for the whole of Australia right now. We have 80% mildly ill patients, and 14% of our patients will need a hospital. They will be hospital ill, they'll need to come in, and 6% will be critically ill. Fever is very common, that's a given, and respiratory symptoms are common. Very few patients have hemodynamic compromise, and very, very uncommon GI symptoms. And we found that most of our patients have a normal white cell count, but they're lymphopenic. Sorry, white cell count is largely normal, but there's some lymphopenic almost all. And interestingly, the AST and ALT is always elevated. And the CRP, very, very mildly elevated, and procalcitonin on all patients with that here in Western Australia is always normal. And CK is a bit elevated in some patients, maybe attributable to the muscle X that they have, myalgia. I've talked about this PPE and droplet PPE. And all these aerosolizing procedures will need N95. So intubation, extubation, bronchoscopies, tracheal aspirates, any break in the vent circuit, prolonged CPR, potential aerosolizing. There was a question of when patients presented to the emergency department, and of course this was always going to be a headache. So we imagine a patient presents who's asthmatic, and they need oxygen, or they need to be nebulized, or they need some oxygen, and the blanket rule that was passed to all departments is that you'll never, the maximum, we are going to go non-rebreather mask. If you're going to use a non-rebreather mask of 15 liters, they have to be in a negative pressure room. So in a normal bay, in a normal bed, we are not going to go more than 8 liters per minute on a Hansen mask. We are never going to nebulize these patients. We are going to use only a spacer with bronchodilators. And of course it was, or a child who comes in with croup, and you cannot even nebulize adrenaline, and maybe you have only all your bays are taken. So it was a bit of a headache. All the patients, most of the patients who needed admission and went to HDU, we initially started with just this basic oxygen supplementation, aiming for SATs of 94%. And when they settled, then we aimed for 90%. Unless they were they've been chronically hypoxic, patients who are always chronically hypoxic from COPD and all that, then you could start at 90%. And if this failed initially, we are just going straight for an intubation. And actually, we have changed this now, and we are intubating less frequently, and we are going for high flow nasoprons or non-invasive ventilation CPAP. So we've seen that high flow nasoprons is good evidence base for hypoxic respiratory failure. We always use a single room environment, or ideal negative pressure room. If we don't have that, we'll go to a single room with appropriate equipment, that is PPE. And if not, then we'll just use a resus bay, which has curtains of barriers, and make sure there are no patients less than 3 meters next to this patient. So this is a small protocol that we follow. So non-invasive ventilation, that is BiPAP, CPAP. We have lots of smokers here, and these patients will come in before we know whether they're COVID positive or not COVID positive. The blanket rule in all emergency departments was not to use NIV, CPAP, or BiPAP. And just, it was very, for example, in my department, we have 4 negative pressure rooms, and at one time we'll have 4 patients there. And someone comes in with APO or COPD, and they cannot nebulize. So sometimes, and we didn't have the rapid COVID test then, so it was a bit of a headache. But just use the same precautions as high flow nasoprons. And but the evidence is not great for hypoxic respiratory failure. Actually, some studies showed some worse outcomes, but it does, of course, help with APO, the preload and afterload, COPD, and of course, remember that COPD patients, some COVID patients will have other issues, so treat the patients as a whole and consider NIV with appropriate precautions. Let's put that slide there just to know that COPD patients can have COVID, so we have to treat the pathology and treat the patient and not just think about COPD. When patients went to ICU, there was always the question, we had even before we transfer them to HDU or ICU, we had a frank discussion with the patient if they could talk, or with their family, and ask them about their goals of care. And a common question I used to ask them is asking, regarding your care today, what is most important to you right now? So you have an 85-year-old patient from a nursing home who's demented with a lot of comorbidities. So do you want length of life or quality of care to be kept comfortable? And most of them will say, I want to be kept comfortable. I don't want to be on a ventilator. And then we could just opt for ward-based management, not for med calls. And critical care if needed, maybe we'll have a ceiling of care. And a senior clinician always had to be involved in these discussions. And if a patient opted for this, there will be a very low threshold for ICU involvement in the decision. The decision is made in the emergency department and followed through. I think I've talked about this. One thing I just mentioned briefly is that we modified our RSI, rapid sequence, and we either use sax or rocuronium, saxamethonium or rocuronium. And of course, there is, especially with rocuronium, there is the bagging as you wait for total paralysis to occur. But we stop this and we say you cannot bag this patient. You cannot, if a patient comes in COVID, I think I intubated about 3 patients. No bagging. So you give them, we modify RSI, you give them the paralytic, 60 seconds. You can watch the curve when they're flat, no breathing at all, no coughing. That's when you can open their mouth and track and intubate them, right? And so make sure they do not cough before, and then inflate the cuff. Sorry, not the cough, that's the cuff before you ventilate. And of course, there was always when you're doing an RSI, the rest of the staff, they are waiting and very jittery, watching the oxygen sats drop, but you just have to hold it 60 seconds minimum, whether you give sax or rock. And of course, we always adopted lung ventilation strategy, 4 to 8 milligrams per kilo of tidal volume, and we started around 6 milligrams per kilo, 6 mils per kilo. We kept the respirate around 12, but of course need to increase depending on where they were before. And we did not use a lot of PEEP, but gradually increased. I think the highest PEEP I used was at once was about 25. But we noticed that in the early phase, most of these patients had 2 phases. So and this was even data from other hospitals. So there's an early phase where there is about 2 weeks, because some patients were ventilated for very long. So up to week 2, the patients had very good lung compliance, which was very weird for the level of hypoxia. Some of them came up with hypoxia of about 80 or 70, hypoxemic at 70, and they were very happy, some happy hypoxia. People could live with this before they suddenly deteriorate. And even when these patients were intubated, even without pressure, the SATs improved. The lungs were very compliant. So we're not sure whether it was a lung protective strategy we adopted, or there was a problem on the blood vessel side, whether it was the clots or just a dysfunction. But after 2 weeks, all the patients who stayed on the vent after 2 weeks developed now the usual ARDS picture that we see with bilateral infiltrates, and then we had to use high pressures. And it happened in almost all our patients here. And now we are trying to, because we have more room, and I think the last 10 COVID patients who required HDU, intubation was avoided. We just used CPAP, and this helped, and intubation was avoided. And I think there's some data coming out that actually patients who are not intubated fare much better than intubated patients. There's some graphs, waveforms. So for the ICU intubated patients, we'll see them at 30 to 45 degrees, decompress the stomach, inline suction. And we try not to paralyze them a lot, but initially have to paralyze them. And some of them did better with proning, and you need a team experience to nurse them prone, but we could turn them from side to side, which we found that was fine. We have a therapeutic guideline for community-acquired pneumonia. So when they came in, they got standard antibiotics for community-acquired pneumonia. And then when our cultures came back, maybe 48 hours later, then we could either stop the antibiotics if we've not grown anything, or if we've grown something, then targeted therapy for the bug that we've grown. Hemodynamic support, this patient did not look that was a big picture of this COVID. And of course, in the initial stages to offset the sedation and the aggressive sedation for intubation, there were some of them, about 50 to 60% of them needed inotropic support. So notice some of them will be they'll be more inflamed, they're vasoplegic, and of course, if they have sepsis on top of that. And there's always later on those who develop cardiomyopathy and needed hemodynamic support. Not much fluids was needed because we wanted to run them dry. Just kept the lungs open with PEEP, and just limited inspiratory pressures. And we just very conservative fluid management. Of course, other things in ICU, feeding is important. They're in for the long haul, DVT prophylaxis, and data coming out, these guys have a lot of VTE. So we are using the upper limit of the prophylaxis. So that's about, people get 60 milligrams daily of Clexane rather than 40. So we are using the upper limit. Of course, stress ulcer prophylaxis. And of course, there's always the issue of PPE, so we time our medications. We have to change the timing of our medications to make sure that there's less ingress and egress into the room, to reduce visits into the room. And of course, like in the ED or in ICU, so the bay has to be cleaned, the room has to be cleaned for 30 minutes post after the patient has gone or died or has been discharged. And we're using 70 to 90% chlorine compounds or ammonia compounds. Transport through the hospital if they've been intubated in ED or a special intubation area. So very clear, and the corridors are cleared, staff out, and everybody PPE, and they're transferred, and there's a PCA, patient attendant cleaning after. And of course, we have to look at our staff well-being, look after each other. We're here for the long haul, regular debrief, hot and cold debriefs, establish regular communication lines, and we have a lot of pathways for psychological support. And give them hugs. Thank you.
Thank you very much, Dr. Bahati Moseti. And I think even as you were speaking, I was Googling to see what time it is in Australia, and it's around midnight and 1 in Australia. So we really appreciate
7 minutes to 1 a.m.
Yes, so we really appreciate that you actually took the time to talk to us during that time, like it at that level, and I think we are learning a lot from your experience, and I like the way you've mentioned drive-through COVID clinics and your pre-hospital care. Right now, I'd like to give an opportunity to Idris, Dr. Idris Chikofe, maybe to give us a few comments and on our situation. Then we can go to the question and answer section. Kindly, for all of us, please type your questions in the question and answer chat box. We'll be able to see them, and we'll be asking the questions to the panelists. Thank you very much.
Hello. Can you hear me?
Yes, we can hear you. We can't see you.
You can't see me?
It's really dark.
Yeah, I'm still outside. I'm yet to go home. I've just left the ICU, so you'll have to bear with me. I'm actually doing it from the car. So thank you very much for the good presentation. Those are great insights. And I can see there's a very big difference between Australia and our setting here. especially in the pre-hospital and the triage of patients as they come into the hospital. We're different because we do not have that kind of a maybe intensive care network or emergency department network as has been described by Dr. Mosoti. And I would say the coordination may not have been as good as what has been described, because I think individual hospitals have had sort of different plans for their patients. So Kenya is still a developing country. We are nearly, our population is around 50 million, and we probably have like 500 intensive care beds, of which we were using around 250 before the COVID. So from the critical care perspective, I think we have a long way to go, though there's some good job that is happening in the major hospitals and in the private hospitals. In the counties, we still have quite a number of problems because we do not have like a lot of intensivists or anesthetists. So I'm not really sure what happens when these patients present to the emergency departments, but luckily we don't have as much maybe intense, critically ill patients in the periphery of the country. However, at the beginning of the pandemic, I think there was various stakeholders came together and prepared guidelines. This included infectious disease specialists, anesthetists, and critical care practitioners. In the hospital where I work, that is Kenyatta National Hospital, we had like 2 weeks of simulations where we are learning how to intubate, how to don and doff, how to set up teamworks. We also have those protocols of the most experienced anesthetist or intensivist or emergency physician to be involved in the intubation and the management of the ventilator. But I think the care of the COVID patients is largely driven by the infectious disease teams. So we have had, surge in the number of patients that are critically ill. We have the rich ones and we have the poor ones, and they present with different scenarios. We have on one end, morbidly obese patients coming in with very bad lungs, very stiff lungs, difficult to intubate because of the, body habitus, guys with very huge necks, neck circumference of 30, you find it's really, really difficult to intubate. And we don't have the video laryngoscopes. So we're using the Millers and, laryngoscopes. And in the private hospitals, we mostly use rocuronium. In the private hospitals, we don't have as much rocuronium, so we use succinylcholine. Initially, we had a very low threshold for intubation. Then we realized that we were losing most of the patients, and there's been a shift not to early intubation, from early intubation to timely intubation, so that those patients who already come and they need to be intubated. So we intubate them, and we use various methods of ventilation. APRV is commonly being applied to those patients who come with initially stiff lungs. It is worth noting that the biphasic nature of the disease in the intensive care, as Dr. Mosoti has described, has not been observed in Kenya. We just have patients who come already with difficult lungs, and you just put them on intubation and put them maybe on APRV. And you have those that come with the fairly good compliance, the respiratory mechanics are preserved, and we have not seen them shifting to the stiff lungs. So the ones that come with stiff lungs, some of them deteriorate, but the ones that survive actually take such a long time, 14 days on the mechanical ventilator. We have quite a number of patients coming as newly diagnosed DKAs, diabetics in DKA. And basically, it takes such a long time, it's draining. We try to bundle our procedures because of lack of PPEs. So when you go into intubate, we intubate, put a central line, arterial line where they are available, catheterize, and leave once you're done with all those procedures, because we don't want to really use the PPs a lot of times because they are really, the supplies are not very consistent. We don't have devices like high flow nasal catheters in our country. So we're using, of course, nasal prongs. We're using the Hudson masks. We're using non-rebreather masks, but also the number of negative pressure rooms are a bit deficient in our setup. So basically, of course, the therapeutics aspect is guided mostly by the infectious disease team, while the management of the ventilator and the airway and the hemodynamics is actually managed by the intensivist or the anesthetist. We've seen many patients also having malignant arrhythmias. We have lost quite a number of patients who were previously stable, then all of a sudden get malignant arrhythmia and they go into arrest. We have resuscitated some of them successfully, others we have lost. The ones that have survived are those who probably had an arrest when already clinicians were there and they were donned and ready to do the CPR. So basically, it's been a difficult time because most of us are learning. We have had guys who were not previously working in intensive care. Now they have to learn some of these things, like on the job, as opposed to a situation where no students or no learners were supposed to touch these patients. In our setting, actually, we've had to get a lot of junior boys and girls coming in for the first time, and they're still soldiering on. So thank you very much.
And thank you very much, Dr. Chikofe. I know doing webinars at this time is difficult for us, for everyone. So I think we really appreciate that you've taken time to speak to us. There are quite a number of comments from Patrick Olang, who's saying great presentation and a lot to learn from the Australian experience. And a comment from Rose Njoroge. It's nice to hear your experience. Kudos to Dr. Bahati. I can see several questions. I will ask Dr. Thranira to unmute himself and ask his questions even as we move forward.
Okay. Thank you very much, Nancy. Thank you, Dr. Mosetti. This moment, I have to say that we had a chat with Dr. Mosetti on Monday, and he told me he was traveling into the country starting today, Wednesday. And when he was sharing his experience, I heard the story, and I said, this is a good story for him to share on this platform. So thank you, Dr. Mosetti, for the short notice, agreeing to present, and I know it's 1 a.m. So I just had one question. We had earlier discussed about your COVID testing, and you had earlier alluded to a rapid test that you're doing. Do you kindly want to talk about it for a minute?
Thank you very much. The rapid, so we had a RNA test, that was the 24-hour test. I think the rapid 1-hour test is still it's a PCR-based test. It's I don't have a lot of particulars about it, but of course, when it came in, it was really limited, and it was only consultants could order it. But now it's widespread. But I know some areas are not do not accept it. Like as you mentioned, I'm traveling home tomorrow, and the airliner said I cannot do the rapid test for reasons that they know. So you have to go for the other test. So I think it's still an RNA test, but I'll leave that to the pathologist. I'm not really. I was so much saturated as the head of department with these COVID things that at one time I had to take leave and not go for any meetings because it was too much. But it's a PCR based test, and from our experience here, it correlates very well with the older RNA test that we had, the one that took 24 hours. I hope I've answered the question.
You have answered my question. Sorry, I'm seeing several people have asked several questions using my link, so I'll ask them on their behalf. So how often are you testing your COVID management teams? That's number one. And how often do you rotate the teams that you're working with? And talk more about healthcare workers and COVID positive incident rates amongst them.
All right. Currently, can you hear me?
Yes, I can, Dr.
Yeah. So currently, right now, actually, I'll just talk about an incident in Melbourne. Melbourne has had a repeat wave. And actually, Melbourne has had the highest. We've not seen this rate in Australia. And we had 3 doctors. One of them is an emergency registrar, one of my registrars here who moved to Melbourne. He's in ICU right now, and it looks like he might not make it. He is, I think it looks bad. In Western Australia, we lost one emergency consultant, but he was a cancer survivor, and he was one of the guys who got it. So what happened actually, I'm a member of the SHIC, State Health Incident Committee, and healthcare workers here, I'll talk about doctors. I don't know much about the nursing side, but the best employer here is the public hospitals. And if you work in the public hospital, you have your, what's it called, insurance, indemnity with the hospital, and the indemnity is going to pay you for all health-related, work-related incidences. All doctors who are employed in Australia are paid according to industrial agreements with the Australian Medical Association, has entered into industrial agreements with all the state governments. And this sets out how doctors are to be remunerated, from training registrars to normal they're not abnormal doctors, to other doctors who are not on training programs, to general practitioners, all the way to consultants, senior agreements. And these agreements lay out compensation guidelines. So when COVID came, we negotiated as emergency, because emergency staff and ICU staff are going to be frontline. So we negotiated with the state government. I remember, like, what we said is that if you are working in the emergency department and you have small children at home, or you have a spouse or children who are ill, chronic diseases, the state government got your house. You didn't go home. People left home, and the government paid, or the hospital paid for them. Like in my hospital, Peel Health Campus, we took over one of the beach hotels, and all doctors stayed there. So you go for your shift and you go to the hotel. You could go home if you want, but it was not recommended until the COVID wave was over. Then people went back home, and that was taken care of. Compensation, we also negotiated a new industrial agreement for compensation of health workers, and it was that, for example, I think one of the clauses we got is that if you got COVID or died from COVID, the state government was, if you have a mortgage, the state government was to make sure that your mortgage is paid for your kids and spouse to go, so that will be taken care of. All health workers who had mortgages, the banks stopped all their mortgage payments until for 8 months. That's until February. So nobody's paying mortgage, and that was taken over. That was absorbed by the banks, and they had an agreement with the state government. So that was another boon to health workers. So I mean, people were afraid. I mean, we had seen doctors die in Italy from this, and you don't want to die and leave your family, or if you're going to die on the line of duty, then your family should be well compensated. I'm not saying that the human life has a value. So we rotated the teams. For example, for my department, I went in. So when we come on shift, they are in the morning. There will be three consultants, 3 pheasants, and there will be about 5 registrars. We have RMOs, and we'll have about 12 doctors. So we formed 2 teams. So there was the red team and the orange team. So you come in at 8 o'clock, and you go into your zone. If you are red zone, you'll go 8 to 1 o'clock, 5 hours. That means you rotate 2, 3, 3. So you'll be there for 2.5 hours, and you come out for a break and you rotate. So total in a day, maybe you spend in the red zone, you spend maybe 4 hours maximum, or 3 hours. And then in the afternoon, then you'll come to the green zone after doffing and donning, after doffing all your PPE and having a shower and putting clothes. So there was not a lot of exposure. And so what happened is, if you were exposed, for example, I was involved in intubations of about 2-3 patients. And once I intubated them, I went home. I took them to ICU, settled them, did all the lines, did everything. So we are the only doctors, you've already been exposed. And then after that, I went home and tested. So I came for a test the next day and stayed home until day 8 when I had no symptoms. And then I went for a test and then I came back to work. And of course, when you're home, you're compensated. So any exposure, so if you are exposed to a COVID patient or a suspected patient with respiratory symptoms, you will go home and the patient is tested, is negative, but you'll go home and wait for your test. Or if you have symptoms, you wait for your test or resolution of symptoms, whichever comes last. Then you can come back to work. And you're compensated, of course. That's a normal, if you're staying home, that's a normal working day for you. But we decided, because we had a telehealth thing, so these doctors who are home, we equipped, they were staying in the hotel next to the hospital, so we equipped those rooms with telehealth facilities. So they could help us with telehealth facilities. For example, they could do low consults. Some general practitioners want emergency department help. They want some peripheral people want help. Some junior doctors, maybe someone working 1,000 kilometers from Perth, and we are the hospital, we are the mother hospital covering that. So they'll call for advice. Then you will telehealth in and advise them. So even if you're home, you're doing some work.
Thank you, Daktari. I have several doctors who want to come and work in Australia. I'm just happy with what I'm hearing. You guys are taking care of your doctors very well. Here in Kenya, you're being mistreated. So I'll be looking for a job soon. So my last question to you is, what are the discharge criteria for your patients in home-based care? And then you can comment about the little experience you've had or seen on television or read about the Kenyan experience. What would be your advice to us as you travel back to our country?
Look, I was in Kenya. I come to Kenya very often. Actually, I was isolated in, I was quarantined in February. I came from Italy and I came to Nairobi, and I was supposed to stay home, but it was not very strict. But I did stay home. Let me not stuck in myself. So once we discharge patients, our initial plan, Dr. Kigondu was my classmate, and we share a lot. So our initial plan was this: number one, first of all, presenting to hospital, pre-hospital care, don't call an ambulance. If you can drive yourself to hospital, don't call an ambulance, because you are going to cause a deep clean for the ambulance. If you are COVID, you are going to expose ambulance staff. Drive yourself to hospital. If you are COVID positive, I send about 3 or 4 people home. So you stay home, completely isolate. We give you, the government gives you a pulse oximeter, which you can keep. You have a pulse oximeter, and every 2 days, there's a doctor from the hospital who will call you on an app. You download the COVID Safe app, this Australian government app, and that doctor will call you, put your oximeter in. You can see a lot from video, and then we can have a look and talk to them. So we have one of our registrars. So I designated one of my registrars to be the COVID reg. So when you come in the morning, I allocate you COVID duties. So your work is to go and call the COVID, get the register, go to the computer, see all COVID discharged patients and call them, follow them up on their days, and write notes and put notes in the system. So you went home, the protocol was you went home, isolate from family, go home and watch for symptoms. Of course, I think it's exactly, I've seen a lot in Kenya what the ministry has done, and I think it's really commendable, it's very good. So go home, watch for symptoms, really. We'll educate you about the pulse oximeter. If you have Q-Tex or something on your, do not put any painting on your finger, on your nail, look at your SATs. If your SATs fall below 90, you come to hospital. If you can drive yourself, drive. If you're feeling unwell, then call for the ambulance. Then on day 5, you get into your car, you drive through a drive-through clinic. There's a drive-through clinics. Come in, just like McDonald's drive-through when you're buying stuff. There's a speaker there. You say, my name is this and this. Somebody who on the other end will look at the computer, or your COVID positive, so you're coming for a repeat swab. They go in, PPE, they swab you, and you go home and wait for your app. Your results come back, you are negative, and you have no symptoms, good, you are clear. Results come back, you are positive, of course, you continue isolating. If your results are negative, you still have some respiratory symptoms, you stay home until the respiratory symptoms go, and then you come for a repeat test. So it was, I think it's nearly standard. I think even in Kenya they're doing that, and it's really good. So same standard discharge instructions.
Thank you,
And
Dr.
then, of course, we had a COVID follow-up clinic where people came and were, of course, looking for complications, cardiac, renal, and all that. They are followed up in clinics for 3 months. They are registered and they are followed up for 3 months.
Thank you, Dr. Mosetti. I think the last question will be from Dr. Winnie Mwangi. Winnie?
Hello, how are you? Dr. Mosetti, thank you so much for your presentation. It's really informative and gives quite a different perspective as to what we're facing here. Just a couple of things to ask. Considering you're an ED physician, what criteria are you using to intubate? Because currently what we have in our situation is, in agreement with your statement, I concur that we're really trying to delay intubation. Majority of our patients were still, titrating oxygen therapy up to where, as we don't have high flow nasal cannulas at the moment, some places do, but not really, we cannot safely say we do. If you get to non-rebreather masks at 15 liters and you're still saturating below 90%, if you're unable to self-prone, if your PF ratio is 150 or below and your tachypneic above 30, that's what we're using as a criteria to currently cancel the patient now going forward on intubation, because we tend to have happy hypoxemics, like you said, who will be between 88, when they're self-prone, they go up to 96. So for your current situation, what are you using to dictate or say to the patient, we've reached a point where we've done all we can in terms of non-invasive or in terms of the oxygen therapy we can provide without intubation, and now we need to tube you. So what are you using?
All right, I think to answer your question, we do not have strict guidelines. So we don't have strict guidelines. I think the patients have been intubated from number one, clinical gestalt. And I say this patient is trying to die in front of me, so I've stopped them from dying. But I have intubated one patient for staff safety. This patient was SATs of about 88, 87%, but they're working extremely hard to breathe. They're tripoding. They had a really nasty looking X-ray. Ultrasound just showed a lot of B lines in the lungs, and they were just full of fluid. We intubated them because this guy was just going to spread this disease all over. So this one I intubated from staff safety. So sometimes some patients here, and I have to admit, some patients in Australia were intubated very early for staff safety and the nursing safety point of view. But I think as I said, we are trying to avoid intubations at all costs. But of course, patient physiology, I said, they're very hypoxemic. They're not responding to first line oxygenation attempts. Then you step it up, and the high flow nasal prongs, they are not responding, and some of them now go into a negative pressure room, and you do by CPAP on them, and actually CPAP has avoided a lot of intubation. You put them on CPAP and they improve, but now they're not improving and they're still working hard to breathe. They are going into respiratory acidosis, they're dropping their bundles, then they get a tube. So I will say they're not very strict, and the ED consultant, or then not even the anesthetic, the ED consultant will pull the plug and say, you're getting a tube now.
All right, sorry, just one more question. Yeah. We are having quite, like Dr. Threnner actually alluded to, when it comes to our PCR testing, we are finding that you may take samples today, but results are not coming back for a week, maybe even more. You're not even sure if that sample reached there in time, if it's viable anymore. So we're trying to adopt a more, if you're clinically symptomatic, using HRCT, high contrast CT scans to try and guide us vis-a-vis waiting for the PCR to come back. Are you also in a scenario where you're using chest CT scans to guide you, or is it just supplementary?
No, not really. I think we are very lucky here that actually, like an intubation will not depend on the results. That will depend on purely the patient. I have very few patients I've gotten a HRCT, and these are the patients who will be 2 weeks, post 2 weeks in ICU. Then we'll do CT scans because we just do serial ultrasounds, non-invasive, repeatable, easy to get, and they'll just get X-rays. So really, no, we are not using imaging to guide us on intubations and guiding therapy. Imaging is the imaging we'll do here will, of course, guide our suspicion. This is probably COVID. But, you have to understand that, we've not seen a lot of COVID. We've been extremely lucky. We've not seen a lot of COVID. And I think the wave is coming here. It's hit Victoria, and WA, we are getting it. But hopefully we don't. The borders are closed totally. Like getting out of here, you have to get a ministerial approval to leave the country. So hopefully they're going to keep it that low. We have not seen a lot of COVID. My colleagues over East, that is Victoria, New South Wales, and Adelaide, have seen more COVID than us. So radiology really is our guiding stuff, and we try and develop our own local guidelines. It's frowned upon to quote a study done in the US. You'll be asked, why can't we have to use our own guidelines here? So we are really looking inwards and trying to develop our guidelines here. And we are just lucky that now with the rapid COVID test, then you have a rapid COVID test, 45 minutes, you have your answer, and the patient looks like they're crashing, they're trying to die, then they get the tube.
Thank you. Thank you so much, Dr. Mosetti. Again, I'll tell you, thank you for preparing on short notice, and welcome to Kenya. And once you come, meet up with Dr. Chikofe, and you can interact and teach us a lot and exchange ideas. Over to you, Nancy.
Thank you very much, Thuranira and Dr. Mosetti. We have a few minutes before the end of this session, and I'll ask a few questions that have been asked. There's one thing you've actually mentioned. You got to a point where you stopped going for the meetings, for the COVID meetings. And so how do you deal with like burnout? While I've seen like Australia is really taking care of healthcare workers, and we probably should all apply there. But like, how do you take care of burnout amongst healthcare workers? And then there's a question from an anonymous attendee. Now that there's the issue of a new wave coming and COVID is here with us. In Kenya, the borders have been opened. So what should be the advice, or rather, what are you doing to ensure that this disease does not spread as much in terms of the public health perspective?
For me, I was always in the SHIC committee. I was always for open borders because I think it's really draconian here, and people are complaining that we are in a dictatorship. For example, I work I work in Perth. My hospital here is in Perth, but I also consult in a regional hospital called Geraldton, which is about an hour flight away from Perth. When the flights were cancelled, I couldn't fly, so I had to drive, and you couldn't get out of the state. You had to get a letter. I think just like in Kenya, you couldn't get out of Nairobi. And now Western Australia has locked its borders completely. We are not allowing people from overseas. We are like a different country from the rest of Australia. So, and these guidelines, the Premier of Western Australia is advised by SHIC mainly, the State Health Incident Committee, which is made up of emergency medicine directors, ICU directors, and a few politicians. So I think what now we have been trying to push, about 30% of us in SHIC, we have been trying to push for open borders and basically come in and get a test at the airport and isolate for 2 weeks or 10 days. Now, actually, there's some evidence that within 10 days we can be cleared. We have come to recognize that COVID is here with us. It's not going anywhere. So, look, I think it's all about isolation and following public health guidelines and just getting ready for the inevitable. COVID is here with us, and actually that's why I'm even traveling home tomorrow. I know there's infections or spiking numbers are going up, but then does it mean that we stop our lives because of COVID? I don't think so. So really, isolation, masks. I'm not sure. I don't even know whether mass testing is really we've stopped mass testing in Western Australia. We just targeted testing to symptomatic patients and patients who present to hospital. So I'm not sure about mass testing really. I mean, I think that's a public health question and a political question, and which will stir up a lot of emotions. So that's my own view, and that's not necessarily the correct view. In terms of burnout, the legislation here with the Australian Medical Association is that doctors, including trainees, shall work for 38 hours a week in whatever profession, whether be it a surgeon, be it a registrar, is 38 hours a week. More than 38 hours a week, then if the hospital needs you for more than 38 hours a week, then the hospital shall be penalized, and they shall pay the doctor penalty hours. If you want to work extra locums, then you have to get authority from your director to go and work in another hospital. You can go and work in another hospital provided you met your hours, but that is normally frowned upon. And you know what? If you make a mistake and your indemnity insurance guys know that you've been working maybe 50 hours a week, then you might find yourself in strife. So I think that's sort of put in a way or designed in a way to avoid people working a lot and to avoid burnout. So it's really, hours are really closely guarded. But some things like telehealth, where consultants can work from home and senior registrars can work from home, are allowed. I mean, I think it's not considered a very heavy clinical load. But of course, there's burnout. Like when I was these ship meetings and a lot of emails, I could open my inbox, my government inbox, and I find 200 emails. And here, people, you have to reply to an email, even just say yes, because if you don't, then you are deemed as lazy or not serious in your role as a director or something like that. So it really gets to you. And I think the way I've dealt with it personally, it was very difficult during as a registrar for about 7 years. It was hard. I mean, you had to meet your registrar commitments, but now, at least as a consultant, it's easy. I can choose my hours, I can choose my leave days, and I can choose which times to be off and on. So at least it's manageable. But burnout is real, especially amongst emergency physicians. It's really fine. It's happened a lot, and we have a very short career. I think I'm nearly retiring myself.
Thank you very much for that. And maybe just two last questions now before we give, you can give us your parting shot. And there's something you've actually said that referencing studies that have been done in the US or wherever is looked down upon. So I'm just wondering what sort, like in Australia right now, which studies are you doing? And like in your hospital, what studies are ongoing for COVID-19? And question from Lomang James. So with the COVID-19, have you seen a change in patient-seeking behavior in Australia? Are patients not now presenting to the emergency departments, and how is that reflecting in your country?
Maybe I'll start with the second question. Yeah, there was initially when Australia, I think when numbers started going up, and we definitely noted a reduced number of presentations to the emergency department. And I think at one time in my department, we normally see about maybe 200 people, 250 a day. And at one time we saw only 30 patients. So it definitely affected their health seeking behavior. And it became, people came late. people came late. I remember in that week, we had 12 out of hospital cardiac deaths. People had chest pain and they were afraid of coming to the emergency department because of COVID. So it really, it affected their health-seeking behavior. And we had to, now I think there was even public health education on TV and on mobile phones. Look, if you are sick, you still go to the emergency department. If you have chest pain, you still have to seek help. And then numbers started coming back again. And of course, with the elective surgeries delayed, some of those chronic conditions or stable conditions suddenly became acute and needed management. So we saw many of these patients coming in with acute or chronic conditions. So patient behavior was affected about for three weeks. But I think now it's come back to normal and people have learned to live with COVID and they've come in. We used to see a lot of malingerers in the emergency department and they're still coming back, drug seekers and all that. So right now it's back to normal, but there was definitely a dip in numbers at one time. In my hospital right now, we are doing, first of all, there is the vaccine. There's one vaccine from Melbourne, which has shown a lot of help, and I'm one of the volunteers. We've gotten the vaccine. We are on clinical trials. So we go and get the vaccine. You volunteer, we even recruiting more volunteers. You go get the vaccine and you follow up on bloods and all that. So that's one of the trials that is going on. We did the hydroxychloroquine famous study. We are part of it and we threw that out. We don't use that. And there are many, many more. I mean, every department has a research wing here. Like my department, we've done snake studies. There's an ongoing big snake study. We're doing a lot of COPD interventional study, and many cardiac study. We are developing a path chest rule. The emergency department. We were involved in the stroke thrombolysis trial and follow up from a big Italian study that showed effectiveness of half dose of Metalise in strokes. We are doing that. And actually from my hospital and hospitals in Perth, we have our own protocol about stroke thrombolysis, which was developed locally in Perth. Yeah, and many other studies. So I think when you're presenting, we encourage registrars to use local studies first. And each hospital, like now, I have a vote for research. I have a vote of about $100,000, which if any registrar wants to do something, we can allocate them funds to do that. So it's really encouraged to do studies and to collaborate. There was a big sepsis study, ARISE study, which Australia participated big time in it. I participated in that study. So yeah, we participate in local trials, local studies, and in international studies collaboration as well. So, which I think is a good thing.
Thank you very much for that. I think we, as Kenyans, have a lot to borrow from what you're doing in Australia. And once you come to Kenya, please help us to get to the level that you are at in terms of management of COVID-19. And we would love to have you around at KNH. Maybe your parting shots for now, even as we close the session. What would you like to share with us that maybe you can implement and as a parting shot?
I think Kenya is doing well, and I mean there are a lot of brilliant doctors from Kenya can compete in the rest of the world. We are equal to everybody else. I think what lets us down is allocation of resources from government, and I'm sure if we have the resources that we have here, we have a lot of brilliant minds there, and we shall reach where we are. I mean, I think Kenyan doctors are as equal as everybody else. Everybody else is just that we don't have. And actually, I think Kenyan doctors are very, very good. We have a few doctors here from Kenya, and whenever we go, we shine. So keep it up. And I think we, Kenya Medical Association and the board, KMPDU is fighting for our rights. I'm still registered in Kenya and I want to come back home. So I'll be back home. And let's keep on doing what we are doing, and hopefully the government shall improve on its health commitments.
Thank you very much. I'll give an opportunity to Dr. Idris to give us a parting shot, even as you're practicing at KNH. What should the counties note?
Thank you very much for this second opportunity. I'd like to tell the counties that we are really working hard, because right now we have newer societies that are coming up, like the Critical Care Society of Kenya, and we have a cause that is meant to empower the junior doctors or those doctors who may not have experience in critical care. So we have started training doctors in intensive care medicine. We run a course called the Basic Assessment and Support in Intensive Care. So at the end of the day, I think we will have so many of us with skills to at least manage a patient, stabilize a patient initially, so that maybe when eventually an expert comes, they'll find a patient who is better placed. So we're working hard, and I think we utilize this pandemic to better our health systems. So there's hope, despite all that has been said. There's a lot of hope in Kenya. Thank you very much.
Thank you very much. I'd like to thank Dr. Bahati Moseti for even your presentation and for taking the time at 1 a.m. to talk to us about the Australian experience. Thank you, Dr. Idris Chikofe, for also taking your time. You're outside in your car presenting, so we really, really appreciate. For all the attendees who've actually attended the session, we'd really like to thank you also, because without you all, then there'll be no webinar. Thank you to Mwenda, who's been setting up even at night, Dr. Kinuthia, and for everyone who's attended. Have a good night and safe travels to you, Daktari.
Thanks a lot, and I hope I'll see some of you soon when I come home. Asante sana.
Asante.